So acute myocarditis is a cause of ventricular dysfunction where the heart muscle doesn't squeeze as well as it should. Now, what's important is that itis actually means inflammation, and so therefore the cause of this poor contractility is actually due to an inflammatory response of the muscle itself. It's a fairly vague term because it doesn't actually talk about etiology, although we will discuss this in a bit more detail in a bit, because usually when we say acute myocarditis, people have a conceptual framework of what that means. They have an idea of what it is. So we'll discuss that in a bit more detail in a bit. Now, it's truly unclear in terms of how big of a problem this is, particularly because we only know those people who come, the patients who come to our attention. And I know that sounds like like it sounds pretty clear, but the fact is that myocarditis, an inflammation of the heart, is quite a variable disease with an entire spectrum. And so, we can say is that we know the scope of the problem based on the upper end of that spectrum. Okay, and so the denominator is approximately 1 in 100,000 cases per year. It's an important disease with, in some studies, as high as 12% mortality. So that is quite significant. And when we look at those with with sudden infant death syndrome, and again, this is now an old term because SIDS is a lot more narrowed in terms of its definition now. But in previous studies, it was approximately 17% of those infants who died suddenly and unexplained. And so we can see that it has significant impact across the ages. And part of the problem, and I think this is in its core, one of the biggest issues with myocarditis, it's how vague and how variable the presentation can be. There are many people who have mild inflammation of the heart who are completely either asymptomatic or, as the term that we've learned with COVID, minimally symptomatic. Maybe a little bit of chest discomfort associated with the viral illness, mild chest pain, or maybe just a little bit breathlessness when you're doing your stairs at the same time that you have a viral illness. Nothing that would trigger you to go see a physician or go to the hospital, but clearly something which is important. But that would be on the milder end of the spectrum. When we look at the more severe end of the spectrum, you can have significant respiratory distress, increased work of breathing, wheezing. You can have major chest pain, palpitations, syncope in terms of fainting. You can have shock and you can have death in terms of people who present suddenly with sudden death and then in retrospect had myocarditis. I've purposely left out gastrointestinal symptoms because I think this symptom complex actually merits further discussion. In studies done previously, they've shown that a large number, up to 20% actually, of kids with myocarditis will present with isolated GI problems, specifically abdominal pain, vomiting in the absence of diarrhea. And so it's something that is actually quite problematic and difficult for emergency physicians who, during viral season, as we're coming up to now and in early spring, where everyone seems to be walking around with enterovirus or or another GI bug, and vomiting and diarrhea is common, to try to identify that patient with myocarditis is a huge challenge. Now, in this study, which was done out of the coroner's office by, now this is dating myself, this was around 10 years ago, by a fellow at the time. They looked at kids who presented with sudden death and at the coroner's office, and those who were then identified to have died due to heart disease. You will see that a third of those kids had myocarditis. The rest, as you can see, is a smattering of those with congenital heart disease or cardiomyopathy. And so you can see that myocarditis can present, the diagnosis of myocarditis may only be known after the child dies. And that's a catastrophic presentation, and one which doesn't necessarily allow you to intervene. So this is the chest x-ray that one can definitely see during myocarditis. You can see from this chest x-ray that you have some cardiomegaly. You have both left and right atrial enlargement, as you can see a double shadow that's over here. You can see that the lungs are wet and they're congested because the left ventricle doesn't work very well, and therefore that sort of pressure backs up into the lungs. Now, if you were to see a chest x-ray like this, particularly during viral season, it would be striking in that the heart is enlarged, and it would trigger you that even if, for example, you weren't suspecting myocarditis as a potential etiology, this sort of enlarged cardiac silhouette may prompt you to sort of reconsider that. The challenge is that not everyone who has myocarditis presents this way. Many, particularly in the acute fulminant myocarditis, will present with a similar type X-ray, but with a narrow cardiac silhouette, because the symptoms or the impact on the heart has been so quick that the heart hasn't had time to enlarge, and therefore you wouldn't see this larger, broader heart silhouette. Now, so if you can't really rely on the chest x-ray to diagnose myocarditis, well, how about the ECG? The ECG definitely looks at the heart. And many people have learned that an ECG can be helpful in terms of defining myocarditis. And particularly, what we learn about in school is that those with myocarditis have diffuse ST segment changes, meaning the ST become elevated in the setting of inflammation. And if the heart tissue itself is severely affected, that the voltages become really small because they're quite edematous. What we know, though, however, is that although those can definitely be consistent with myocarditis, the ECGs in all the spectrum of myocarditis is completely insensitive and nonspecific. One of the most common or most sensitive findings of an ECG is sinus tachycardia, that kids with myocarditis tend to have fast heart rates. And that's because the heart muscle itself isn't working. So therefore the heart has to compensate by beating faster. That being said, other findings that you may see in this condition is that you can see heart block of variable degrees, anywhere between first degree heart block all the way to complete heart block. You can have ventricular arrhythmias, which tend to be extremely difficult to control. And then I've actually seen a child oscillate from heart block to ventricular arrhythmias, which was pretty problematic. Now, this is a normal heart. I show this because I'm not sure if everyone's seen an echo before, but this is the left side of the heart. This is the right side of the heart. The ventricles are down here and the atrium at the top. And you can see, you don't have to be a cardiologist to see that this ventricle over here is squeezing really well. This ventricle here isn't seen as well, but from what we can see, it's actually squeezing well as well. Now, this is a heart that we would see in the setting of myocarditis. If you were to compare it to the last one, you can see that the left ventricle, which is over here, is moving, but it's not really squeezing. It tends to be just fluctuating in that space. The right ventricle, which is on this side, is also moving and squeezing very poorly. You don't have the context to say whether the heart's enlarged or not. In this child, the heart wasn't enlarged. But you can see that the squeeze of both sides is affected. The other thing that you can see is that the heart tissue itself, and I think this would be a lot more nuanced an approach, and I wouldn't expect those who aren't cardiologists to necessarily pick up on it, but you can see that the heart tissue itself looks more speckled, and is consistent with edema of the heart tissue itself. Now, the topic of conversation was fulminant myocarditis, and we have to distinguish fulminant myocarditis from acute myocarditis. So acute myocarditis is myocarditis that presents suddenly. Now, fulminant myocarditis is a subset of acute myocarditis that is a lot more specific. And the reason is because there's a lot of there's a lot of specific findings with fulminant myocarditis, and it actually does denote a different outcome. So fulminant myocarditis is usually preceded by upper respiratory tract infection, a viral infection of some sort, usually around 1 or 2 weeks before, but we've seen the gamut where it's longer or sometimes much shorter. It's really characterized by a sudden initiation of some cardiac symptom. Now, usually we'd say that it's cardiogenic shock and poor cardiac output, but sometimes it's sudden death. Sometimes it's sudden ventricular arrhythmias or heart block, but it is something that comes on quite suddenly. The left ventricle is usually severely dysfunctional, but it's not dilated because, again, it hasn't had the time for the ventricle to accommodate that it's not squeezing very well. And like I said, ventricular arrhythmias are common. As I mentioned from the very beginning, most people, when we talk about acute fulminant myocarditis, we think of predominantly of a viral etiology. And most times, particularly in children, you would be 100% correct. Common viruses include those that you see listed there: parvo, enterovirus, Coxsackie, which is a form of enterovirus, adeno, influenza, et cetera, But I put this here just to remind people that there could be other causes of acute myocarditis, and including bacteria, trypanoma, which would be syphilis, Borrelia burgdorferi, which would be Lyme disease, and Mycobacterium, which would be forms of TB. You can have allergic myocarditis, and you can also have inflammatory myocarditis. You can see that from this sort of timeline that the dominant virus that cause myocarditis actually changes over time. Now, it doesn't mean that in 1980 you didn't have adenoviruses causing myocarditis. It just meant that at that time, parvovirus was more common within the population, and things cycle. There are other viruses which are constantly there, like Epstein-Barr virus, CMV, etc. But they never actually reach that higher threshold of affecting the majority of people. Now, what is it about these viruses or bacteria that actually cause inflammation of the heart? And because when we go in and actually look at the tissue, we don't always find viral particles there or other bacterial particles there. And the fact of the matter is that it's not necessarily the virus itself, although it can be, but it's really the interplay, that relationship between the virus and the body's response to that virus or that entity. And it is that response which targets the muscle tissue and causes the inflammation. Now, part of that response changes. So in the acute phase, where you have the virus either infiltrating or causing your body to build those immune globulins against the heart tissue, you have this massive infiltrate into the heart. So you see, due to the immune response, you see all these neutrophils and macrophages and lymphocytes come into the heart tissue itself. And as the initial macrophage response releases the cytokines, now you have it becomes more of a lymphocytic response. And basically what they're trying to do is neutralize an invader that may or may not be there. Now, the acute myocarditis happens within days, and usually that's associated with actual viruses within your system, and at least in the blood. But once the virus clears, there's still this subacute period of inflammation, okay? And that takes up to a few weeks. Now, here it's giving you specific timelines, 4 days, 14 days, etc. The truth of the matter is their viruses aren't on the clock, nor is your body. And so this is vague sort of time references, but it's more in terms of the pathophysiology that I want people to focus on. And as that response sort of wanes and the inflammatory system really starts to be blunted, there's healing process and this chronic myocarditis. Now, what's important is that as the body heals and as the heart heals, it doesn't necessarily go back to normal. And so a lot of where there's infiltration and inflammation, you can get fibrosis and scar tissue. That can lead to the heart becoming dilated and poorly functioning. And it can be long-standing and for some life-limiting, but for the rest of their entire life. Lifelong, that was the term I was looking for. So how do we diagnose myocarditis? There's no clear consensus. It's interesting. A lot of people talk about, say, this child had myocarditis, even though we don't have there's no definitive evidence to that, but just a constellation of signs and symptoms are consistent with that diagnosis. In those cases, a lot of us would say presumed myocarditis or clinical myocarditis, but effectively, it's where we look at the signs, symptoms, and the investigations that we've reviewed so far that would support that diagnosis. Over the last little while, there's increasing support for troponin measurement. Now we know troponin is released when the heart tissue itself is damaged, and therefore you can find troponin in the bloodstream on examination. But there was a good study which so far hasn't been published, but the findings were striking, that those with fulminant myocarditis actually had a huge troponin leak. So the levels of troponin found in the blood were 1,000 times higher than what you would what you would expect normally, and definitely much higher than what you would see from other causes of heart dysfunction, including cardiomyopathy. And it's important to note that cardiomyopathy is also a cause of ventricular dysfunction, but unlike myocarditis, the cardiomyopathy is due to an inherent problem with the heart muscle, and therefore it's not an inflammatory response. There's still heart injury, but it's not inflammation. It's intrinsic to the heart, to a muscle problem, whether it's genetic or not. Recently, with the increase in the availability of MRI and the improvements of MRI technique, these advanced sequences that they run are able to look for edema or swelling of the heart muscle, which is often seen by delayed enhancement, which is a specific sequence that is run to examine for that. So that may be evidence of myocarditis. But lastly, you can look at the heart tissue itself. So the gold standard is actually to do a biopsy and actually look at the pathology. And with that, you can actually see whether there's inflammation. And this goes all the way back to the 1980s, where they developed what's called the Dallas criteria, which is a structured approach of pathologic assessment of the heart. And effectively, what you're looking at is you're looking to see if there's active myocarditis, where there's active infiltrates of the myocardium associated with evidence of cell death. Okay. As we mentioned earlier, the infiltrates at that point tend to be lymphocytes. But if it's really early on, it could be neutrophils, or if it's an allergic type pictures, it could be an eosinophilic infiltrates as well. Sometimes you can see some inflammation, which is sparse, which may or may not be related with cell death. And at that point, we would call that borderline myocarditis. But effectively, here is the full Dallas criteria, where you could see all the different types of myocarditis, or different characterization of myocarditis. Now, this is what normal heart tissue should look like. You can see this beautiful pattern of lines of heart tissue, all arranged in a very organized fashion. And in the setting of myocarditis, you can see how that is completely disrupted, as you have all these cells coming in. And so these are infiltrates and lymphocytes. You can see that the heart tissue itself is no longer in continuity, and it's being broken down as cells die. So this would be a classic picture of myocarditis. Unfortunately, we don't always see this classic picture, even in those where we believe they do have myocarditis. And why is that? Well, part of the problem is that myocarditis is patchy. The entire heart may not have the same pattern. And because you're not sampling the entire heart, and even if you go in to sample areas, you may just happen to sample an area that doesn't have that degree of inflammation. For less severe disease, there's also what we call inter-observer variability, where you've got two professionals, experts in the field, who would say, well, this may be myocarditis, and well, maybe not. And so because they don't come at both extremes as yes and no, that can lead to some ambiguity, or it can definitely lead to some uncertainty. It's definitely helpful if we use imaging to direct sampling, but that's not necessarily always possible. And it's also helpful when we see sampling in combination with other evidence of myocarditis. Now, I'd be remiss not to bring COVID into the picture. So this is what we call multi-system inflammatory syndrome in children, which is a COVID-related entity associated with heart dysfunction. And it's unclear necessarily what the pathological findings are with this disease. So we know that some kids who have had COVID or have been exposed to COVID may have heart dysfunction, but it's unclear if the heart itself, the tissue, shows similar findings as myocarditis, as what we traditionally think of as viral myocarditis. So how do you treat myocarditis? Well, right now you have to support them. So you ventilate those who need to be ventilated. You give inotropes like epinephrine to those who need the additional squeeze, recognizing that that in and of itself may promote arrhythmias. And in the severe case, you can use forms of circulatory support. Now, are there any medications that can help reduce the impact of myocarditis? And the answer is that it's unclear. People have used immune therapy, such as steroids and IVIG. But the truth of the matter is that the evidence to support that is weak, and it's quite controversial. Some people, there are a couple studies that have shown that with presumed myocarditis, the use of IVIG has helped with the clearance of the virus and reduced the immune response. And in a different study, there was evidence that it may improve left ventricular function, but other studies have shown no difference at all. And so what we end up having is that people are either believers or non-believers, and it varies significantly. The one thing to consider, though, that now in the setting of COVID and MIS-C, as I showed you the criteria earlier, that MIS-C, or multi-system inflammatory response in syndrome in children, is treated with immune therapy. So that would, if you think that you have myocarditis in the setting of COVID, immune therapy would be indicated. Now, for mechanical circulatory support, this is an ECMO circuit. This is where we take blood out of the heart, out of the body, and oxygenate it, get rid of its carbon dioxide, and push it back in. So doing both the heart and lung function. And we can use that to support those at the most extreme. And we would use that as a bridge to recovery, to help to allow to the heart to recover, a bridge to go onto a more chronic assist device, or even in some kids as a bridge to transplant. As I mentioned, though, acute myocarditis and fulminant myocarditis do have a different implications. You can see here that those with fulminant myocarditis, if they get through the acute period, tend to recover. So 95% of those with a fulminant myocarditis will recover and live a very long life. However, you have to get through that acute period where you're at high risk of sudden death. On the other hand, if you have myocarditis that presents acutely, which means that every patient has an acute presentation of sorts, but those with acute myocarditis, which is not fulminant, tend to have an outcome or a prognosis similar to that of cardiomyopathy, where at 5 to 10 years, you have a close to 50% survival off of transplant. Dramatically different. The important thing, which we don't, sometimes it's hard to differentiate though between the last two slides, is how do we identify those who definitely have a fulminant course versus those who have more advanced form of acute myocarditis? And the answer is we don't know. In the study that a colleague of mine has done but has yet to publish, those with higher troponins were actually associated with better outcomes. But that has yet to be proven in a large cohort. And so with that, I finish and I open things up for quick questions.
Questions for Dr. Flo?
Sorry, I can't see if there's any chat.
Yeah, there's nothing in the chat.
Okay.
Although, yeah, no. Oh, amazing lecture.
Okay. Well, if anyone has any questions down the road, Cecilia has my contact number, my contact email or even number that she's free to share. And please feel free to reach out. And yeah, I hope you have an amazing rest of the course that Cecilia has prepared for you guys.
Thank you so much, Alex. We'll see you in semester 2 as well, toward the end.
Bye, everyone.
Bye. Right. So our next speaker is Dr. Brian Mccrindle, and he's going to be talking to us first, I believe, on rheumatic heart disease.
Okay, so let me just find everything.
Okay.
So I'm